Okay, so today we're going to start talking about airway clearance therapy, or ACT, and we're also going to talk about CPT. So CPT stands for chest physical therapy or chest physiotherapy. So this is another tool that we have in our toolbox to help our patients clear their secretions. So clearing secretions from the airways can be either invasive or non-invasive. So an example of invasive would be suctioning. So SX is also short for suctioning. So if you see that in reports or shorthand from other medical professionals, SX stands for suctioning. And then non-invasive would be CPT, PEP therapy, the vest, and Medaneb. So today we're just going to go over CPT, and in the next set of days, the next topic, we'll go over PEP therapy, vest therapy, and other ways of airway clearance. So indications. What kind of diseases and conditions would benefit from airway clearance? I'll give you a few seconds to think about this. So some diseases that benefit from this would be cystic fibrosis is a big one, bronchiectasis, and then ciliary dyskinetic syndromes as well. So airway clearance therapy uses non-invasive techniques designed to improve gas exchange. So basically, we want to do what we can non-invasively before we have to suction out a patient because it's not pleasant. They don't like it, and there are more adverse effects to having to suction a patient, which we will talk about when we get to trachs. So pretty much we are giving them tools and exercises to assist in mobilizing and removing their own secretions. So when the slide says the broad application of airway clearance therapy is costly and ineffective, what they mean is that we need to be choosing the right patients. So not every respiratory patient in the hospital is going to also receive CPT and airway clearance therapy. It would be ineffective and it would be costly to the hospital because although doing CPT is typically done by hand, you are paying that respiratory therapist their hourly wage. So if it's not working, there are other patients that can be seen by that therapist where they are going to be more useful. So know that not all patients need this. So airway clearance with CPT promotes removal of secretions with gravity. So removal of secretions with gravity. So we are positioning the patient, and by positioning them, we are also going to do percussion and vibration. And this is going to move the secretions from whatever area of the lung that we know that there are retained secretions. We're going to move them towards the larger airways and eventually to the upper airways so that they can cough it out. So this is useful for patients who have an ineffective cough or if they have a disease that is associated with copious or chronic production of sputum. So it's useful for patients who have an ineffective cough and a disease that is associated with copious or chronic production of sputum. Okay, so normal airway clearance. So know your normals. Always know your normals. So normal airway clearance requires a patent airway, so an open airway. So if a patient does not have a patent airway, that's when we provide that airway. Whether it's an endotracheal tube or trach, Something needs to be open so that it can come up and out. They need to have a functional mucociliary escalator and an effective cough. But the patient should also be adequately hydrated. So hydration. Because if you have a patient who has thick, nasty, tenacious, sticky mucus, it's going to be hard to get it up and out on its own. So mucus is created by secretory cells called what? Clara or club cells, goblet, and serous cells are the cells that produce mucus. And remember, you have those ciliated epithelial cells which move mucus up and towards the trachea and larynx for expectoration. So remember, the ciliated cells have these cilia, these little hair-like things that are up here. And remember, they can beat back and forth. So they're going both ways because it's going to help wave the mucus up and out. So this is also known as the ciliary beat or the mucociliary escalator. So if you have a problem with your cough or your ciliated cells are not working, or there's less of them, or you have some sort of dysfunction in the cells, that's going to cause you to not be able to adequately move mucus as well. So like with bronchiectasis or COPD, especially CF, the cilia are there and they function and they work, but their mucus is extra thick and tenacious, so it gets stuck in between the cilia. So this is when we need to help intervene to help get that mucus up and out for these people with disease processes. So a healthy person produces 10 to 100 mLs of airway secretions a day. Okay, so moving on to a normal cough. So know this. Okay, so cough is one of the most important protective reflexes. Cough is one of the most important protective reflexes. So number one, so the first part of the cough is irritation. So some sort of abnormal stimulus comes in and irritates these airways. So the body sends an impulse to the medullary cough center in the brain. And then, so some common causes of irritation is inflammation. So pneumonia or infection. Number two would be mechanical. So a foreign body. Think of, we say we're eating and something goes down the wrong tube. We say that. So a foreign body will cause you to cough. If you're talking with a friend and you're drinking water and they make you laugh and you take a breath in, it's going to irritate and you're going to cough. Number three would be chemical. So smoke, pollutants, things of that nature. And then number four would be thermal. Very hot or very cold. And when we get back to campus, you'll notice that if it's cold outside or the classroom's really cold, I cannot stop coughing. It just drives me crazy. Okay, so after we have irritation, we have inspiration. So deep inspiration, afferent signals are received. So that impulse in the medullary cough center, those signals are received, and the signals cause a deep inhalation. So 1 to 2 liters. So 1 to 2 liters. And that's for normal adults. So this is the gas that's used to force out mucus or the foreign body. So it's irritating. Big breath in, and it's a big deeper breath because we want to push whatever is making us cough out. And that is why it's a cough is one of the most important protective reflexes of the body. Okay, so after we have that deep inspiration, we have number 3, which is compression. So this only lasts 0.2 seconds. So this is when you can see it here, the glottis closes and a forceful contraction of expiratory muscles. So this arrow here, you can see the muscles are contracting. So it's going to increase alveolar and pleural pressures up to 100 millimeters of mercury. And then finally we have expulsion. So the cough itself. So the glottis opens and it creates that pressure gradient here. And because it's been building up, it wants to come out. So a violent, high velocity expulsion of airflow will come out of the lungs. So this is when they're hoping that mucus or the foreign body or whatever irritation it is that the body wants it up and out. Okay, so we've talked about normal airway clearance. Let's talk about abnormal airway clearance. So any abnormality that alters airway patency, so the structure of the airway and its ability to remain open, mucociliary function, so anything that impedes the mucociliary escalator and the ciliary beat, strength of breathing muscles, so your neuromuscular patients, your patients with end-stage emphysema or COPD, thickness of secretions. So a good example of this would be your patients with bronchiectasis and cystic fibrosis. When we get to pediatrics and I teach you about cystic fibrosis, I will explain more why their mucus is the way it is and why it's so sticky and thick and just tenacious. And then cough reflex. If your cough reflex is inhibited or they don't have one, they're gonna have abnormal airway clearance. So retention of secretions. So know what retention of secretions can cause. So full obstruction or mucus plugging. Okay, so let's say this is our airway up here and you have a full obstruction. So even if you just have a mucus plug here, when the air comes into the airway, it'll still go into this alveoli, but it will not go. It'll get stuck past this mucus plug, causing this alveoli to collapse. And if you have enough mucus plugs, you're going to get large areas of atelectasis. So if this was a mucus plug up here, that air is going to come in and stop at that mucus plug. So both of these alveoli will be collapsed. So then you get lobar pneumonia, for instance, and you have lots of fluid or lots of secretions that are in those airways that will cause atelectasis. Because it will cause atelectasis, you have to think of the capillary beds, excuse my drawing, around the alveoli. So there's no oxygen going in. There's none to cross that AC membrane. So your patient is going to be hypoxemic. And that's because it's going to be shunting. And then you have partial obstruction, which restricts airflow. So it'll increase their patient's work of breathing. So think about what a patient might look like if they have an increased work of breathing. So they could be using accessory muscles. They could be pursed lip breathing. They could be wide-eyed and scared, increased respiratory rate. They could be air trapping. Their lungs could be over distended. So back to the AC membrane, if their lungs are over distended and they're air trapping and they can't get it out, they're squishing these capillary beds with the alveoli. So because those capillary beds are then, let's say this is what a normal capillary would look like. If they're squishing it with the alveoli and it's thinner, those little red blood cells are not going to be able to pick up that oxygen because they can't cross into that capillary bed because it's either a smaller lumen or it's totally closed off and squished. So that will cause VQ imbalances. Okay, so we want to consider airway clearance therapy if there is an abnormality that impairs mucociliary clearance. So if there is an abnormality which impairs mucociliary clearance, cough reflex, or results in increased secretions, we are going to consider airway clearance therapy. So what is a common emergency intervention that respiratory therapists do that can lead to impaired cough and mucus clearance? Intubation and tracheostomy. We are bypassing their airway, so therefore they're not going to be able to cough it up and out on their own. Typically, people who have chronic trachs have learned how to do it, but in an emergent situation, intubation and tracheostomy acutely will cause an abnormality to airway clearance. So you need to know some diseases that are often associated with abnormal clearance. So internal or external compression of the airway lumen. So internal would be someone who has a tumor in their neck or their throat and it is pushing on their trachea, so that decreases airway lumen. Tumors inside their lungs that is causing an obstruction would also be another example. Cystic fibrosis is a huge need, and it starts when they're babies all the way through to adults. They have a huge need for us to give airway clearance. Bronchiectasis. So since you haven't gotten to bronchiectasis yet, it is bronchiectasis or permanently dilated and damaged airways. So because they're dilated and they tend to be more floppy, they're prone to be obstructed due to retained secretions. They've lost that elasticity, so the secretions can sit and pool in their airways. And then neuromuscular diseases can cause a weak cough. They don't have that diaphragm strength. So muscular dystrophy, ALS, myasthenia gravis, cerebral palsy are just a few. So any disease that affects airway patency, the composition or production of mucus, ciliary structure and function, and cough reflex. Okay, so this is caused of abnormal clearance for intubated patients. So it may be an endotracheal or a tracheostomy tube. First of all, it impairs the closure of the glottis. So the glottis is not able to close, to compress. So the endotracheal tube is a foreign body. So therefore, the body thinks that it needs to force it out. So it can increase mucus production because it thinks that foreign body is there to do harm. The endotracheal tube itself also blocks the normal mucociliary elevator. So the cilia isn't able to beat where the tube is at to help get it all the way up and out. You have inadequate humidification. So we're bypassing that upper airway and normal humidification, so it's going to dry out secretions. We skipped one. So tracheal bronchial suctioning. So because they are unable to cough it up and out on their own, we will suction them. And suctioning them and passing that catheter can stimulate more secretions to be made. Okay. High FiO2 values will also impair ciliary function. the beat of the cilia. It'll kind of stun those cells, but it'll also dry out secretions. Okay, and then we move on to these drugs. So these three right here, take a second and think, why would these affect mucociliary clearance? Okay, so while a patient is on the vent, they're going to have general anesthetics, so sedation, and this is so they can better synchronize with the vent, and so it causes amnesia-like effects as well, so they're not going crazy. Opiates and narcotics for pain. What these have in common is it will decrease their respiratory drive. Therefore, they're taking shallow breaths. But we give them the volumes that they need. And then also, they are unable to generate that force to cough. Okay, and then if a patient has an underlying pulmonary disease, it's going to impair that mucus clearance as well, on top of being intubated. Okay, so let's talk now about the indications for us to recommend or order airway clearance therapy for a patient. So I want you to take a few seconds and think about what a patient might physically look like, an acute patient who would need airway clearance therapy. Okay, so an acute patient might have an increased work of breathing or shortness of breath. So that could be accessory muscle use. It can be, they may tell you they're short of breath. It can be pursed lip breathing, wide eyes, maybe a panicked look on their face. They may have an uncontrolled cough. And that's due to a constant foreign body or some sort of irritation. So uncontrolled cough. They may be hypoxemic. They may be cyanotic. Now, what breath sounds do you think you would hear on patients that would need airway clearance therapy? So some breath sounds you may hear are crackles. You're hearing that air move through mucus, which makes that crackly sound. It's also referred to as rhonchi. Someone may say they sound coarse. You may hear coarse crackles. So there's several different terms you might hear meaning the same thing. Okay, so remember, this one is acute. So this is for acute patients. So copious secretions. So that is defined as 20 to 30 mLs expectorated a day. Per day. So the body makes 10 to 100 mLs of secretions a day, but the body reabsorbs it, or it's not expectorated up and out. So copious, 20 to 30 mLs expectorated a day. The inability to mobilize secretions. So if they are on high pain medications, or they're not moving up and around out of bed, they're unable to take deep breaths, they just need a little extra help. If they have an ineffective cough, so think of abdominal or thoracic surgery. So abdominal or thoracic surgery. So it's painful. So I will teach you once we talk about guided coughs, about splinting. They don't want to cough. They're in pain And then if they're on pain medication on top of it, their cough isn't going to work to get it up and out. And we don't want it to just sit in their lungs, because then we are worried about infection and atelectasis and everything else that comes with it. Okay, so for airway clearance therapy for chronic patients. So these are your big diseases that you will always do airway clearance with. You have CF, bronchiectasis, ciliary dyskinetic syndromes, COPD patients with retained secretions, So if they're unable to get it up and out. So the goal of airway clearance therapy is to assist the patient in mobilizing secretions. So the goal of airway clearance therapy is to assist patients in mobilizing secretions. Okay, so for patients who have aerosolized meds with their CPT, especially with the CF and COPD and these chronic disease processes that require this, we want to give the bronchodilators before the CPT, before they do any airway clearance. These bronchodilators are going to help open the airways, so hopefully they can improve the transport of the mucus. Then we're going to do the CPT, and post CPT, that's when we'd administer inhaled antibiotics, because this can improve lung deposition. So we have those lungs opened up from the bronchodilators, and then we're moving the mucus out so that it's not blocking where we want those anti-infectives to go.
Hello everybody, how are you doing today? I hope you go back to Canvas soon so I could see every one of you are funny sometimes in the TikTok videos.
I hope you enjoyed your message from Marilyn. So let's do a little case study to assess a patient who might need airway clearance therapy. So the RT is called by a nurse to determine a care plan to assist a patient who is having difficulty clearing secretion. The patient is an alert, obese, 45-year-old man who underwent general anesthesia and surgery for gallbladder removal 3 hours earlier. Physical signs indicate retention of secretions, but there is no history of lung disease. Auscultation reveals coarse expiratory crackles. The patient is breathing spontaneously, however, his breathing is shallow and he has a very weak cough. Visual clues indicate the patient has severe pain in the epigastric area. The patient was given an injection of morphine to assist with pain 1 hour earlier. Okay, so let's dissect this. So starting from the top, so keyword here would be obese. So because the patient is obese, it could cause abdominal restriction, and that could impair the cough. And then he went under general anesthesia. So that could impair the cough and mucociliary transport. So not only was he under general anesthesia, he was given morphine an hour prior. So that's going to decrease his respiratory drive, causing shallow breaths. And that indicates that he was in severe pain. So he doesn't want to cough. So also weakness post-op 3 hours. He has a decreased cough because of the surgery itself. Pain will decrease the desire to cough. Okay. So the gallbladder is behind your liver. So it's on the right side of your rib cage. So remember, that's the area, the abdominal area and thoracic cavity. That pain is you're not going to want to cough because that pain, it's going to hurt. Okay. So the patient would be indicated for airway clearance therapy. He needs help moving the secretions and hyperinflation therapy. So an IS. We want him to take big, deep breaths. We haven't gotten to incentive spirometry yet, but we'll get to that soon. So the most common post-op complication is atelectasis and pneumonia. So if those secretions just sit down there in the bottom of the lungs, they're going to develop a pneumonia. We want to make sure that we elevate the patient's head of bed 30 to 45 degrees. By doing this, we are going to prevent aspiration. We also want to encourage hydration. So before a patient has surgery, they've been NPO, they haven't been able to eat and drink. So once they are feeling better, and the nurse says it's okay to have food, water, ice chips, we want to encourage hydration because that's going to keep the mucus thinned out and help it from being retained. We also, when patients have had surgery and they are still able to walk, when it is safe for them to walk, we want to encourage them getting up and out of the bed. This is going to help them move mucus in their lungs, but it's also going to help blood flow and prevent blood clots as well. Okay, so let's talk about the use of airway clearance therapy as a preventative measure. So evidence only supports that prevention of retained secretions is only proven with acutely ill patients and patients with cystic fibrosis. So acutely ill patients that might benefit from prevention treatment would be those who have had that thoracic or abdominal surgery or are unable to get up and move and walk around to help mobilize those secretions. With those acutely ill patients, if they are able to get up and be mobile, we want to combine exercise or mobility with airway clearance therapy methods. Or we also want to focus on body positioning. So body positioning. Okay. And then patients with cystic fibrosis, another important, an important aspect of airway clearance therapy is exercise. We should always encourage our patients with CF to exercise. I know that I heard all her doctor's appointments at clinic, they always ask, well, what are you doing? What's your activities like? Are you playing any sports? So Marilyn's done dance, she's done ice skating, she's done basketball. She does a little bit of everything, and she loves to be outside. She loves to run. Running's a good one because it's a natural mucus clearing technique. So definitely encourage exercise. A physical therapist is also part of the CF team. So if you're working at a CF clinic, whether it's adults or kids, you are going to be part of a really big team. And part of that team is respiratory therapy and physical therapy. Okay, so we went over that little case scenario a few slides ago. So these are going to help you determine whether your patient needs airway clearance therapy. So physical findings. And these are for both acute and chronic patients. So if someone has a loose, ineffective cough, it may be described as junky or rattly. If you hear someone cough and you can just hear lots of movement, they may need airway clearance therapy. A labored breathing pattern. So if they're tachypnic, if they're using accessory muscles to breathe, if they just look like they're struggling. If they have coarse inspiratory and expiratory crackles, or one or the other. If you can hear crackles in their lungs and they aren't able to effectively cough it up and out, they're going to need airway clearance therapy. If they're tachypnic or tachycardic, because that mucus is pooling in an area and so their heart rate's up because it's trying to compensate for that area of lung where they're not oxygenating or oxygen can't pass through the AC membrane. They might have a fever if they have an infection of bacterial pneumonia or viral pneumonia and they have retained secretions, they might have a fever. a chest radiography demonstrating atelectasis or infiltrates. So it may say patchy infiltrates or fluffy infiltrates in the reading from the radiographer. So who needs airway clearance therapy? Those with an ineffective cough, and then those with a disease that's associated with massive or chronic sputum production. So bronchiectasis, chronic bronchitis, cystic fibrosis, neuromuscular disease, because they have that ineffective. Okay, so there are 5 general approaches to airway clearance therapy. They can be used individually or combined with each other. Today we are just going to go over CPT, but we also have coughing and breathing techniques, positive airway pressure adjuncts, which are PEP devices, vibratory PEP, high frequency positive airway pressure devices. Then we have vests, and then mobilization and physical activity also act as airway clearance. Patients should actively participate in their treatments, otherwise they're going to be ineffective. So again, patients should actively participate in treatments for them to be effective. So chest physical therapy is also known as chest physiotherapy, CPT, or percussion and postural drainage. Go in and look at the PowerPoint that I've attached below this video. For some reason, the positioning when it transferred over didn't work right. So what CPT is it uses body positioning and gravity and mechanical energy to help mobilize secretions. We will manually strike the chest wall with cup hands in a rhythmic fashion. And I will post some videos and I will show you a video of how to do CPT. We can also vibrate the chest wall with a mechanical device, so a handheld device. A vest will do the same thing, which we'll go over in our next section. But there's also hand percussors that are mechanical. So what we're trying to do is loosen the secretion from the airways and move them into the larger airways so that they can be coughed up and out. So a patient is placed in various positions so that gravity can help us drain the secretions from the lung segment to the larger airways. Positions are let me write this for you. Positions are generally held for 3 to 5 minutes. So it depends on the patient condition and the patient tolerance, and then we assess if it's working by the patient's response. Did they just cough out a huge glob of mucus? If they did, it's working. Or have their breath sounds changed? Are they less short of breath? Sometimes are they more short of breath? And then you move to another position for another 3 to 5 minutes and they cough something out. So the total treatment time is ideally not to exceed, 15 to 30 minutes. Now, you'll have some CFers who they know their bodies very well, especially the adults and the older kids know their bodies very well, so they may need longer treatments. So the takeaway here is we are manually striking the chest wall. The hands need to be cupped and it needs to be rhythmic. And then vibration can happen through a mechanical device. Okay, and we are using gravity. Gravity is what's going to help assist us in draining the secretions. So limitations. You need to know your limitations. So it requires the help of a caregiver. So if you participated in that CF Education Day this past week, the guest speaker at the beginning was talking about how he was so excited to go to college because he had a vest machine and he wasn't going to need someone there to do CPT on him manually like his parents had. So it was very freeing for him. There's a lot of chronic kiddos, whether it's CF or neuromuscular disease, that their caregivers are the ones that are always providing their CPT. So CPT's effectiveness may depend on appropriate positioning. If they're not in the right position to help move that mucus through those airways to the larger airways, we're doing CPT for nothing. Some patients may not be able to tolerate or get short of breath in the Trendelenburg position. Remember, that's head down, feet up. So patients who are unable to perform concurrent aerosol therapy. So during CPT, no small volume neb, MDI, or DPI. You need to be able to do just the CPT on its own. And then you do your therapies. Or you do your MDI first, your CPT, and if you have anti-infectives or pulmozyme or anything of that nature, you're going to do that after your CPT. To initiate CPT, first you want to identify the appropriate lobe or segment of the lung that has the retained secretions. So you can do this via chest x-ray or auscultation. Second, you want to schedule the treatment 2 hours pre or post mealtime. We want to help avoid nausea or vomiting, which can lead to aspiration or GERD. The third step is try to coordinate with pain meds. If you are seeing a patient, especially due to like surgeries, you want to talk with the nurse and make sure before you start the treatment that they've had pain meds. If you go into a patient's room and say the nurse is just giving them narcotics, you maybe want to go see someone else and do a small volume neb or an MDI or another therapy to let those pain meds kick in. 4, explain the treatment prior to starting. If it's a patient that's never had CPT or postural drainage, you should explain why you're moving them around and pounding on their back. 5, you need to check for incisions, monitors, IVs, oxygen tubing, anything that can get in the way or can cause more damage. You're not going to do CPT over someone's incision. You want to make sure that you're not accidentally causing more pain. And then last step, vitals and breath sounds, you need to monitor both. So when you're doing CPT, maybe move the monitor if it's in the room, or check their vitals before if they're not on continuous monitor. Make sure you're paying attention to the patient's facial expressions. Has their breathing pattern changed? Check their breath sounds pre and post to make sure that your therapy worked or that you were over the right segment or lobe, or if that mucus moved, if you need to move sections. And then monitor sputum. It's okay if they start coughing and you think they're going to cough something up, stop and let them get it up and out. So some patients may need oxygen while you're doing this, and that's okay if they have a change in oxygen. If you sit your patient up, so rule of thumb, if your patient is in distress, you get called to a rapid or assess a patient and they're short of breath, sit them up. That's going to help them breathe better. So opposite, when you're doing CPT, a patient may be in the prone position or Trendelenburg, and they may need oxygen therapy just while you're doing this until they get sitting back up again. That's okay. If they're vigorously coughing, they're not just coughing up what you moved and spitting it out and then you can keep going. If they're vigorously coughing, sit them up to let them catch their breath and give it a few minutes before you try CPT again. So here we have your positions for postural drainage. There are better images in the White's clinical competency book. On page 313. Okay. So our first group of positions are going to be flat. So we have, I will just label them in red. And with all of these positions, you're just going to have to memorize them. Find out what works for you. If flashcards work, a Quizlet, whatever works for you to help memorize these positions. So first you have supine, which is here. So this is laying on your back looking up. So this will drain the upper lobes and the anterior segments. So remember, anterior segments is the front. So if you're looking up, it's going to drain the top of the lungs. These are good for your neurosurge patients. Okay, and then you have the prone position. So this is on your stomach, on your belly, facing down. So you're prone. This is what we do with patients on the vent in ARDS if they're having a hard time oxygenating. So this will drain at the upper lobes on the posterior segments. So up here. And then laying on your side. So that's prone, mostly prone. It's going to drain your right posterior lobe. So next we have Fowler's and reverse Trendelenburg. So in this group, it's going to be heads up, (45 to 90 degrees). So if you have your patient up and they are prone, like this patient here, this is going to drain the posterior parts of the lungs. If your patient is facing forward or supine, it's going to drain the anterior portion of those lungs. In order to get the apices of the lungs here, they're going to be posterior and they're not going to be supine or prone. It's sitting more straight up and hunched forward just a bit. Okay, so number 3, we have Trendelenburg. And that means 15 degrees. So your head is down 15 degrees, and the foot of the bed is up 12 inches. So here, this one, are both Trendelenburg. So you can see, it's kind of hard to see in this picture, but you can see it says raise the foot of the bed at 12 inches. And depending on what side the patient is laying on, it's going to drain different areas of the lungs. So it will drain the lingular, lateral, and medial segments. It helps manage hypotension because you have the foot of the bed raised. So it's going to help shunt that blood back to the core. So the heart's not going to work as hard to get the blood from the bottom of the body back to the vital organs. It's also going to support perfusion to the brain. We're using gravity to help us. It's contraindicated, so always know your contraindications. It is contraindicated for head trauma or brain surgery. Okay, so our last one is Trendelenburg. (30 degrees). So the head of the bed is down 30 degrees. Oops. And the foot of the bed is up 18 inches. So that would be this one, this one, this one, and this one. Okay, so it's going to drain the lower lobes, the basal segments, it can be difficult for patients that are dyspneic to handle. So everything is coming down, the blood, the mucus, everything in the body is using gravity, is pushing it down towards the core of the body. So patients who are dyspneic may have a hard time doing this position. Also, gravity is also going to push the diaphragm up towards the lungs and put pressure on the lungs. This Trendelenburg position is also contraindicated for head trauma and brain surgery. When performing manual CPT, there are a few things that you need to remember. So you want to have your hands cupped like you see in this picture. You're not going to raise them too much more than 3 inches away from the chest or the back. Remember that you need to check the chest x-ray if you have a specific area to focus on. Preventative CPT, so if you had a patient with CF, you would perform percussion over all areas of the lungs that you can. So know this, areas to avoid. So you want to avoid bony structures. You want to avoid the spine, the abdomen, and the breasts on women. As RTs, we also perform vibration. So that's when you place both hands over the area that you were percussing or performing CPT, and you have the patient take a few big breaths, and then as they're breathing out, you gently shake the patient. So I will post videos. I am going to make a video of myself performing that, probably on my husband. So when you are performing either percussion or vibration, you want to do it against a thin layer of cloth. You don't want to cause too much friction, and you can cause rashes, or if they have dry skin. Plus, you want to keep yourself safe as well. You should be wearing gloves. If you're not, but you should, you also want to have another layer in between you. So you want to, here are the steps, and I'll write them down. So you want to cup your hands. And you're going to make sure that your finger and your thumb touch together. You don't want any spaces, because with your hands cupped, you're going to get the right amount of pressure needed doing CPT to have it be effective. Oops. You want to relax your wrist. And then percuss over the area that needs to be drained. So this is something that you don't need equipment for. So once you watch the videos and you feel comfortable, you can practice on someone that is in your household. You can practice, you can do this on kids, you can do it on adults. I'm not sure if dogs would let you do it. My cat would probably let me do it. But practice this, and maybe think of a song, and so you can get that rhythm. So a little scenario. Again, look this slide up on the PowerPoint that I've attached in Blackboard. That way you can read it and have a reference. So a physician's progress note indicates a potential bacterial pneumonia localized to a patient's right middle lobe. The patient has coarse breath sounds on the right mid-lung and a non-productive cough. The physician orders CPT 4 times daily. And in his notes it says, until the radiograph clears. So take a minute and think about what positions the RT should select for postural drainage, and where should the RT provide percussion. Okay, so let's look at this. So we're looking at the patient's right, middle lobe. So therefore, we would put the patient in Trendelenburg at 15 degrees. So down, the head of the bed is down 15 degrees, and the foot of the bed is up 12 inches. We would have the patient rotate 45 degrees to their left side. So when you are putting a patient in a position, you want to put the bad side up for percussion, because you're not going to be able to drain anything. You want gravity to pull it down. Gravity is not going to pull it down, the mucus down and out, if you put the bad side down. Okay. And then for percussion, it should be done on the right anterior chest wall between the 4th and 6th ribs. Okay, and a side note here, so if you see 4 times daily, you might also see it as QID, means 4 times a day. Okay, so this is a picture of a mechanical percussor. So manual percussion equals hands. Mechanical percussion is using a tool, an electronic device. This will deliver a constant rate of rhythms and impact force. So it decreases caregiver fatigue. So when you practice manual CPT at home, I want you to do it for 15 minutes straight and see how tired you can become. Most of these percussors have settings so you can adjust depending on patient comfort and patient need for the level of percussion and the rate, how fast or how slow it goes. So like with all therapies and treatments that we do, we are looking at the outcome. We want to make sure that they are improving. So when we're assessing the outcome of this therapy, it can be from the immediate treatment we just gave, or we can be tracking it over the course of days. So a change in sputum production, that can be from something as simple as they just get it up and out and they're getting better, maybe they're becoming more mobile, or it can be a combination. So you're doing airway clearance and CPT, and then they're also getting antibiotics for an infection, and maybe that infection's clearing up. So we want to see a change in sputum production, and that's for acutely ill patients. For chronic patients like CFers, it may just be making sure that their sputum production doesn't go up, or that they're able to get the sputum up and out. A change in breath sound. So we're looking for improved air movement. And this can be over time, or it can be just after the treatment. So if we have improved air movement, we're going to have effective therapy. Change in dyspnea level. Are they complaining of shortness of breath? Has it improved? Is it getting better? We should also be getting periodic chest x-rays to help make sure that we're getting the right areas and if there's any improvements. We want vital signs to improve from therapy. So that would be decreased heart rate, decreased respiratory rate. It can take up to 24 hours to see a patient's positive effects. So even if you don't hear increased breath sounds, but maybe you've dislodged something and they just weren't able to cough it up during that treatment. And we want to encourage our patients to drink and hydrate. Encourage them to drink and hydrate. If they're on the vent, we are hoping to see that we're able to take PEEP down. And we'll go over PEEP and exactly what it is during our BiPAP lecture. If we can change settings on the vent in a positive way, then we're doing our airway clearance properly. Okay, so what if a patient has diminished breath sounds, but after CPT you hear coarse crackles? What should you do? So if you hear diminished breath sounds at the beginning of your treatment, but then you finish your therapy and you're doing your post vitals and breath sounds and you hear crackles, it means that the patient or that the therapy was effective and you should have the patient coughed, because there wasn't that air movement through that mucus before. There was just solid mucus, no air movement, but now it's moved, so you want them to cough. So that means secretions are now in the larger airways. So if you hear coarse crackles after their treatment, you should have the patient cough because the mucus is now in their larger airways. So a rule of thumb with an adverse reaction or compliance, stop the treatment and stay with the patient until stabilized. So that means if they were very dyspneic or they were vigorously coughing to the point that their heart rate skyrockets or their blood pressure drops or they get dizzy or nauseous, sit the patient up and stay with them till they're stabilized. You don't just want to sit them up and say, all right, well, I'll let someone know that we couldn't do the therapy. You need to stay with that patient. Okay, charting is going to be something that we do all the time. So when we talk about CPT and postural drainage, you need to make sure that you chart the positions used, the time in their positions, and you can just round this about 3 minutes, about 5 minutes, and then also chart the time as a whole. So they were doing postural drainage for 15 minutes. The patient tolerance, were they compliant? Did they tolerate one side better than the other or one position more than the other? Indicators of effectiveness is talking about, do they have improved breath sounds, improved vitals? Did they cough anything up? And you also should chart sputum production, and then you also need to chart what the sputum was like. So the amount, color, was there a smell? So that the next RT can say, oh, well, they produced a small amount with so-and-so, but they produced a large amount with me. Maybe we're really getting the stuff moving. Or for the past day or two, they've been charting that they've had large amounts of sputum, but now it's just a small amount, so maybe they're getting better. Maybe their antibiotics are working. It's starting to connect the dots. So charting should help you connect the dots when you're treating a patient. And then anytime there are any adverse effects, so with everything, they were nauseous, I had to stop because they got lightheaded, or they tolerated this position but not another position, I had to stay with them until their heart rate was stable, those type of things. So we need to reassess for the need for CPT with patients in the hospital every 2 to 3 days, because hopefully they get better. We want them to get better. We want the antibiotics to work, and if they've been drinking lots of water, and you'll have these rock star patients that do everything that you tell them, and they are just awesome. And then you're going to have these patients who just drag everything out just because they're not compliant or they don't want to work that hard at it. So you're going to have both. And then for patients that are at home, we're going to reassess every 3 months. Now you're going to have some disease processes like cystic fibrosis, neuromuscular disease, cerebral palsy. Some of these chronic conditions, you're not going to need to reassess because it's just something that they have to do all the time. Now you could reassess on those patients that maybe they were sick, maybe a kiddo or a grown-up with cerebral palsy got a pneumonia and got an infection and went into the hospital. And so then we had to ramp up and increase treatment needs. That would be a time at home that you would reassess. Okay, so like always, know your contraindications. And these are on page 957 in Egan's. So an untreated TB, so untreated tuberculosis, poor or unstable cardiovascular system, so that would be unstable and untreated hypertension, hypotension, CHF. If they're not stable or they're maybe end stage of a heart condition, we're not going to do this. You're not going to do CPT or percussion and vibration over incision sites. So make sure that's something that you hopefully will get and report from the RT before you. Oh, they're here because they had their gallbladder removed. Well, you know that on that side you don't want to do CPT where the incision is. And that should be part of your physical assessment when you treat that patient. An untreated pneumo and chest trauma, so rib fractures, pulmonary contusions, maybe they got in a car accident and they had a seatbelt mark. You're going to be able to see that bruise on their chest and you're not going to want to do CPT over that area. And then pulmonary embolism. Okay, so this slide, it's not letting me play the video, so I will post the video so that you have it for reference. So this video is about a couple and the woman has cystic fibrosis and her husband is her caregiver and they have a YouTube channel called The Fry Life and it's awesome. Nicole actually turned me onto this and she would show this video during class. So something that happens with chronic illnesses is these patients have a preference. They know exactly what they like, how they like it, what works for their bodies. You have CFers who can feel where in their lungs they need to work on more. So that's something to keep in mind. If you are working with patients, especially with my experience with CF, your caregivers are like family. So, and especially adults who have been in and out of the hospital and they really get to know their RTs and their nurses, you're going to develop these relationships. So then it's going to kind of be like clockwork. So critical thinking. Under what conditions is Trendelenburg position contraindicated? Cardiac atrial arrhythmia, increased ICP from head trauma, anemia, or excessive secretions in the bases. So the answer for this one is increased ICP from head trauma. So you may be like, well, you just said that cardiac instability is a contraindication for CPT and postural drainage. So that while that's a correct statement, this question is specifically asking for Trendelenburg. So B would be the best answer. So in cardiac atrial arrhythmia, if it's stable, it doesn't say it's unstable or it's an acute new onset. So the best answer for this one would be B. Anemia doesn't have anything to do with CPT. It's not going to affect how we treat the patient. Excessive secretions in the bases, that's the indication for the Trendelenburg position. Okay, what position would be most helpful in draining the lower lobes and posterior and basal segments? So prone. So with prone, you want to drain, you are draining the back. So you're laying on your tummy so that you can have the affected side up. So that would be the posterior, would be prone. What is the best position to drain the lingular, lateral, and medial segments? So these should say, they shouldn't say inches, they should say degrees. So I apologize for that. But Trendelenburg down 15 degrees. Our last one. So what postural drainage position is most conducive to draining the basal, anterior, and lateral segments? It would be Trendelenburg down 30 degrees. So that's going to have the head of the bed further down than the previous answer at 15 degrees. So if you see it's the smaller degrees, you're going to think medial. If you see down 30 degrees, you should think basal, the bottom.